and you put a bandage on something in the early stages of your injury. You take that bandage off, what do you see? You see that yellow fluid that kind of sits there. I remember I went to ISAR for training, and when I took the bandages off my knees, my knees were just soaked in this yellow fluid. All that is plasma and platelets. You can see the scab starting to form, and you can see the plasma oozing out. You're not going to see the white and the red blood cells, but the white blood cells are there to make sure I don't get any infection from that, and the red blood cells are there to make sure that tissue is still getting oxygen. So anytime you have an infection, the reason that you have an inflammation, or excuse me, an injury, the reason that you have an inflammation is because all four of those are rushing to the site of that injury to try to make sure it has oxygen, fights off infection, gets rid of the carbon dioxide, clots or forms a scab, and has the fluid to make sure that it's still being hydrated. Okay, make sense? So all that is taking place at one time, anytime you have an injury. And this, when we get into burns, when we get into trauma, you'll understand a little better why burns are such a damning injury. Because when burns happen, the first thing you lose is plasma. That's why we do such aggressive fluid resuscitation in burns, because we want to make sure that you stay hydrated, because your body has to have that plasma. The reason people die from burns is not typically because of the burn, it's because of the infection from the burn. Okay? So we have to make sure that that white blood cell can get there, the red blood cells can get there to give it oxygen, and the plasma can get there so that it stays hydrated. Okay? Make sense?
What did you say about the red blood cells earlier?
They carry oxygen and they carry carbon dioxide. Okay? They carry oxygen to the organs and carry carbon dioxide away from the organs. Okay? To be released through the respiratory system, or what's called the respiratory buffer system.
And
Okay?
takes CO?
And it takes CO away from the organs. Yes. It takes oxygen to the organ and takes CO away from CO2, excuse me, away from the organs. Carbon dioxide.
Sorry, my bad.
No, you're fine. You're fine. All right. So now we're going to talk about blood pressure. Okay? This is the force of blood against your artery walls. Your systolic pressure being the high number, this is the maximum squeeze of the left ventricle, or what's referred to as systole, S-Y-S-T-O-L-E. That is the time in which the left ventricle is completely squeezed, and that's the number when you check somebody's blood pressure, that is the high number, okay? And that is complete contraction of the left ventricle, textbook. Complete contraction of the left ventricle, okay? Maximum pressure. Then you have what's called diastole, or the diastolic blood pressure. That's the low number. That is the pressure against the artery when the left ventricle has relaxed. So that's your resting pressure, okay? So systole or systolic is the high pressure when it's maximum squeezed, and then diastole or diastolic is low pressure. Okay? So the way we feel a pulse is we feel a pulse when the blood passes through an artery during systole. So what you're feeling is the actual contraction of that left ventricle every time that you feel for a pulse. Okay? So whether it's regular or irregular, you're feeling that contraction every time that left ventricle squeezes. Okay? Peripheral pulses are obviously your extremities, and then you have your central pulses, which are felt in the body's trunk or near the body's trunk. So when we talk about peripheral pulses, we're talking brachial, radial, tibial, and pedal. Carotid and femoral are your central, okay? And this is them there, all right? So carotid and femoral are central. Brachial, radial, tibial, and pedal, or pedis, are your peripheral, okay? Talking numbers now. Cardiac output. This is the volume of blood. Yes. Yes, the complete squeeze of the left ventricle. That's correct. Yes. Go. See where that is in the book?
What's it for?
The
Blood pressure?
yeah, blood pressure. blood pressure and pulse.
Just strobe while you were there.
It's on 634.
Okay, I got you. Thank you.
Uh-huh. No, you're good.
634?
634.
Okay, thank you.
Uh-huh. So cardiac output. This is the volume of blood that passes through your heart in 1 minute. So this is the heart rate times the volume of blood ejected with each contraction. Okay? So not something we can really calculate in the field per se. We just know that based on perfusion, right? And we can check perfusion, skin color, temp, and condition, blood pressure and pulse. We can tell if a person has a good cardiac output or not. We don't know numbers. That's something they do with interarterial blood pressures, where they actually stick a needle into your artery and can read your blood pressure from the inside. But we can find this out from perfusion. This is the constant flow of oxygenated blood to your tissues. Okay? In the field, like I said, we can tell stroke volume roughly by calculating the heart rate, okay, and the strength of a patient's pulse. So we can tell, not calculate a number, but we can tell if they have a heart rate of 80 and they have a strong pulse and their skin is pink, warm, and dry, we can tell they've got good cardiac output. If they have a heart rate of 130 and they have a weak pulse and their skin is pale and clammy, we can tell they have weak cardiac output or low cardiac output, okay? We have kind of a roundabout idea of how they're doing or what their perfusion status is, okay? To have good perfusion, this is what you have to have. You have a heart that works, adequate fluid, okay? So you have to be hydrated, and you have to have blood vessels that are appropriately constricted to match the volume of blood moving through them, okay? So the pump, the pipes, and the fluid all have to be working in conjunction with each other in order to have a good perfusion status. If perfusion fails, cellular death may occur, and ultimately, death of your patient may occur, okay? You've got to stay perfused. You've got to stay, more importantly, hydrated to stay perfused, okay? So now we're going to talk about patho. And what this means for us is chest pain usually comes from decreased blood flow to the heart, okay? Or to a portion of the heart. Let me clarify that. This comes from decreased blood flow to one or more portions of the heart. If that blood flow is restored, the tissue does well, typically. If that blood flow is not restored, that area of tissue will die, which means that that area of the heart has died, or the heart as a whole can go into arrest. Okay? It's very important that we quickly resupply that area of the heart with blood. And one of the ways we do this is through use of drugs like nitroglycerin. Okay? The reason that this stuff happens is because of atherosclerosis. Now, what atherosclerosis is, for lack of a better way to put it, is this is attributed to the number of Big Macs that you eat throughout the course of your life, right? So, directly proportional, if you'll say that. It's calcium and cholesterol built up in the arteries. As you can see here, as that builds up in the arteries, you can kind of see that it forms caking along the walls, right? And it causes occlusions because we naturally have clots that occur throughout our body, right? And as those clots occur in our body, if we have narrow arteries, those clots are going to get stuck somewhere. If they get stuck in the blood vessels of the heart, this is what happens. Okay?
So pretty much you're playing Russian roulette.
Yes. Depending on how you eat, depending on, health status, depending on working out, things of that nature. Yes. Very much so. Very much so. Okay? The inner wall of the artery becomes rough and becomes brittle. That's the problem there. Okay? As that fatty material accumulates with age. If a brittle plaque breaks loose, or cracks for some reason, the ragged edge of it can get stuck somewhere, resulting in a clot that'll partially or completely block the lumen of the artery, or the inner lining of the artery. Okay? That's where you get your clot formation from. And that's where you get your heart attack from. Okay? Not your cardiac arrest per se, but your heart attack. Okay? So a thromboembolism is a clot that's just free floating through your blood vessels. Okay? The problem is if it reaches an area too narrow, it blocks blood flow. Tissues downstream will suffer from hypoxia, meaning that no other oxygen is going to get through, none shall pass. If too much time happens with that, it's going to cause the tissue in the area to die. And again, this sequence is known as an AMI, or acute myocardial infarction. Okay? An acute myocardial infarction. That is your heart attack. Okay? Myocardial being muscle of the heart, infarction meaning tissue is dying. Okay? Myocardial infarction. Muscle of the heart is dying. Okay? There are three phases when it comes to this tissue. There's ischemia, I-S-C-H-E-M-I-A, which means that the tissue is deoxygenated or hypoxic. There's infarction, which means that the tissue is starting to die. And then there is tissue death. Okay? Now, coronary artery disease, okay, is the #1 leading cause of death in the U.S. Okay? We definitely have very controllable risk factors for this. We have some major controllable risk factors for this, and then we have some minor ones. Some of the major controllable risk factors for this are diet, exercise, things of that nature. And then we have some uncontrollable risk factors. Okay? Are you Pacific Islander or Hispanic? You're more likely to have a heart attack. If you're African American, you're more likely to have a stroke. Things of that nature because of atherosclerotic plaque or because of predisposition. Things like renal artery stenosis, things of that nature. So you're much more likely to have heart problems if you're a minority, unfortunately. Okay? Didn't make the rules, it just is what it is.
Why is that? I mean, is it?
It has a lot to do historically with diet and things of that nature.
Yeah. I mean, that's what I was going to say. I knew it had something to do with, because your body is always changing, no matter what, you know what I'm saying? And, but I just didn't know if there was like a specific reason
Yeah,
from those original regions that they come from, you know what I'm saying, as to why it does it. But.
Yeah, absolutely, and it has a lot to do with the diet, the exercise, the predisposition to things like high cholesterol, sickle cell,
Right.
things of that nature. Yeah, unfortunately. Okay. Acute coronary syndrome. Okay, these are the symptoms that cause myocardial ischemia or the lack of oxygen to the heart. Okay. The first one we'll talk about is angina pectoris. This is chest pain, right? This is your typical chest pain that we talk about, the one that comes and goes, what have you. And then you have the acute myocardial infarction. This is your patient that's having a heart attack because they have a true blockage. Okay. So angina pectoris occurs when oxygen blood supply is less than demand. Okay? So supply and demand. Never thought you'd hear that one again. Alright? If demand exceeds supply, you're going to have chest pain. Okay? Angina or angina pectoris. What you're going to feel is that crushing or squeezing chest pain in the center of the chest or off to the side of the chest. It doesn't necessarily lead to death, but it can be a sign of something worse to come. You can even have the spasm of an artery from a large meal, being scared all of a sudden, where people, feel like they're having a heart attack because they're scared all of a sudden. It usually doesn't last very long. In women, it can radiate up to the jaw, the arms. Okay. It can radiate up to the jaw, the arms. Okay. The mid-back, the epigastrum. Lasts about 3 to 8 minutes, but rarely much longer than that. Okay. It's usually associated with some shortness of breath. Disappears, pretty quickly with oxygen or nitroglycerin. Okay. It doesn't, like I said, it doesn't usually lead to death. But if it's not taken care of, it can. All right. Then we have unstable angina. This is something that doesn't respond to normal treatment. So if we give them oxygen and nitro and it doesn't work, that's what's referred to as unstable angina and could possibly be an AMI. Okay? Stable angina, we lay them down, we let them rest, give them some nitro, they chill, they're good. Okay? Doesn't mean that there's not maybe something more going on, but, usually that's the case. All right? We always treat a patient that's experiencing chest pain, put a star next to that. Treat it like it is till you know that it's not. Because it'll be that one time that you're like, no, it's nothing big, blah, blah, blah. You're not having a heart attack, and, you're just having, epigastric pain, or you're nauseous and vomiting, whatever. And they don't go to the hospital, then they die at home because you didn't tell them to go to the hospital. Okay? All right. So, AMI pain signals death of cells. Okay? These cells cannot be revived. There's no getting them back. Once that tissue is dead, that tissue is dead. Okay? We do have clot busters that we can use, what are called thrombolytic drugs, similar to what we use in the instance of a stroke, or angioplasty, where they go in, balloon inflate it, and put a stent within the first few hours to prevent further damage. Okay? This patient has to get to the hospital quickly. About 30 minutes after blood flow stops to that area, the heart muscle begins to die in that area. At 2 hours, half of the cells in the area may be dead. 4 to 6 hours, 90% of the cells may be dead. Okay? And we're not talking like cardiac arrest. We're talking heart still pumping, because it's going to have some collateral circulation or circulation to get around the area, but there will be times where that area is dying a lot quicker than that. Okay? But we have to open up that artery as soon as possible. This is most likely to occur in the left ventricle, because the left ventricle does all the work. Okay? So that's where usually these clots and things happen. All right? That's why when we look at an EKG, what we're looking at is primarily the left side of the heart. Okay? Because we know that's usually where it occurs. So, AMI is not always due to exertion. Usually it's you're sitting on the couch watching Family Feud and all of a sudden you're having chest pain. It's 30 minutes to several hours and not relieved by nitro or rest. Okay? So some of the physical findings that you'll find with these patients, okay? You'll find a general weak appearance. In other words, they'll have pale, cool, clammy skin. They'll have a weak pulse. They may have a high or low blood pressure. Initially, they'll have a high blood pressure because the body's trying to compensate, and after a while, they'll have a low blood pressure. They'll have fast respirations, or tachypnea, because of the fact that the body's trying to get oxygen, right? It's fighting to get oxygen. And then they'll have altered mental status. Now remember the 5 stages of mentation. They'll be normal, agitated, or normal, anxious, agitated, altered, and then unresponsive. So that's what you're going to see. The longer this goes on, the more agitated they're going to get. Because not only is the brain, or not only is the heart becoming hypoxic, but soon the brain's going to become hypoxic because the heart's not going to be able to pump like it's supposed to. Okay? So it's going to be normal, anxious, agitated, altered, and then unresponsive. Okay? So the serious consequences of an AMI, pretty obvious: death, cardiogenic shock. Okay? We're going to talk about cardiogenic shock here in just a minute. And then congestive heart failure. Because if the left ventricle fails, that means that the left ventricle is